So during your residency, you get to see a lot of cases from different specialties, cardiology, neurology, medical gastroenterology, endocrinology, like that. But your exposure in working up the cases with regards to endocrinology will be comparatively less compared to the other specialties while you are doing your internship or residency. And even in your final practical exams, your long case would be either cardiology, neurology, gastro, or even pertaining to respiratory system, and only rarely you may get a long case with regards to diabetes mellitus. But when you finish your course and when you start practicing, you will find out that majority of the patients that you're seeing will be having a core endocrine problem. Could be in the case of diabetes mellitus, thyroid disorders, both hypo or hyperthyroidism, or even calcium disorders. So a sound knowledge on how to approach these cases, how to evaluate, and finally how to manage it precisely is very important, and that is the sole idea of this curriculum program. So today I'll be just rushing through some of the interesting cases and will be showing you how to approach that particular case and how we arrived at that diagnosis so as to evoke some interest in you with regards to the endocrinology work. Now, first case I'll be discussing is about two brothers with generalized hyperpigmentation. Now, we have two brothers who came to our OPD at the age of 13 and 15 years. They were studying in 8 and 10 standards, and both were having generalized hyperpigmentation for the last 6 years. For 6 to 7 years, they have been having progressive hyperpigmentation involving the entire body. So here in the photo shown, it is clear that they are having hyperpigmentation involving their face, their trunk, their limbs as well. So generalized hyperpigmentation slowly progressing over the last 6 years. So duration I have mentioned, it started initially over the face, hands and thighs, then spread to involve the entire body involving the mucosa. Is oral mucosa including the gums were hyperpigmented. It was not associated with any scaling, exfoliation or photosensitivity which could be associated with certain primary dermatological problems. So in fact, they first consulted a dermatologist for this issue, and the dermatologist referred to us for further evaluation. Now, in medicine, when a patient comes to you with generalized hyperpigmentation, innocuous, progressive over a few years, what are the things that you will consider? Of course, as you know, Addison's disease. So what do you mean by Addison's disease? Addison's disease is nothing but primary adrenal insufficiency. Primary adrenal insufficiency. What do you mean by primary? That means the cortisol production from the adrenal gland is regulated by the ACTH production from the pituitary, which itself is regulated by the corticotropin releasing hormone or CRH, which is coming from the hypothalamus. So CRH, it stimulates ACTH from the pituitary, which stimulates adrenal gland cortisol production. So an insult at any of these levels can result in abnormal cortisol production. So if the cortisol production from the adrenal gland is involved, that means the hypothalamus and pituitary is normal, but the adrenal gland is defective, then the gland will not be able to produce adequate amount of cortisol, and that is what we call as primary adrenal insufficiency, which is also termed as Addison's disease. So why does hyperpigmentation occur in a patient with Addison disease? As you know, the ACTH has got many receptors. We call the ACTH receptors as melanocortin receptors. This melanocortin receptor has got different subvariants. Melanocortin 1, 2, 3, 4 and even 5 and 6 have been described recently. So this melanocortin 2 receptor is present in the adrenal gland, and thereby it stimulates the cortisol production. Melanocortin 1 receptor is present in the epidermal melanocytes of the skin, is present in the skin. So when the ACTH is increasing rapidly, why the ACTH is increasing? Because the adrenal is not producing cortisol. The cortisol is not able to exert the feedback inhibition that it does usually. So due to the lack of feedback inhibition, the ACTH level rises and the high levels of ACTH will act on melanocortin 1 receptor to increase the melanocyte proliferation, increase melanin deposition, and consequently hyperpigmentation. So that is how Addison disease or primary adrenal insufficiency become a differential diagnosis for generalized hyperpigmentation. But at this point of time, the patient is not complaining of any other features of primary adrenal insufficiency. Like obviously from the history, the adrenal insufficiency patients can have adrenal crisis if left untreated for a long period of time, where the patient would be having severe fatigue, hypertension, loss of consciousness, requiring IV steroids, recurrent hospital admissions. There is no obvious history which in the chit which was referred to us by the dermatologist. There was no particular history mentioned. Okay, so Addison's disease, that is how we become one of the differential diagnoses. So the other possibilities, as you know, vitamin B12 deficiency, even though the generalized hyperpigmentation is not very common, but still you should consider it. Being a physician, you should think of broad differential diagnosis, then take focused history, examination and investigations to narrow down the possibilities and finally reach at the diagnosis. Then hemochromatosis again is a possibility because it can characteristically produce a bronze pigmentation due to the deposition of iron. It is an iron overload state. Then certain cutaneous porphyrias are also possible, but again we have not mentioned any photosensitivity, those were absent. So these were the conditions that we initially suspected in these brothers with hyperpigmentation, and being both the brothers being affected, we thought of the possibility of an inherited or a familial disease.